In this episode, I interview Dr. Ranee Thakar about vaginal prolapse. If you enjoy these podcasts, please press the like and subscribe buttons or visit iforgottooaskthedoctor.com. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Dr. Ranee Thakar about vaginal prolapse. Ranee is a consultant urogynecologist and past president of the International Urogynecology Association. She is also the current president of the Royal College of Obstetricians and Gynaecologists. She is passionate about research and is extensively published, and she also has a lifelong commitment to the improvement of women's health globally. As a gynecologist, I am particularly pleased and honoured to have her on the show. Ranee, welcome. Thank you so much for agreeing to come onto the show.
No problem, Gail. Thank you so much.
So, Ranee, I'm always interested in finding out why distinguished colleagues like yourself chose the particular area of medicine in which they chose to practice. So, can you enlighten us as to why you chose the field of urogynecology?
Gail, this is an area I'm absolutely passionate about, as you know, and my interest started, believe it or not, when I was training in India. I completed my undergraduate training in India, and we used to see lots of women coming with gynecological problems, not incontinence and prolapse. Nobody complained about it, nor did we ask. But I used to see big prolapses. I see women who are incontinent, and I always used to ask myself, why don't they complain about it? But more importantly, why don't we ask about it? And it was something that we were never taught in our undergraduate training. And time passed by. We were not asked any questions in our exams, even as undergraduates. And then I came to this country and I recognized that this is a global problem. It's an area that's underreported, under-researched, and it really sort of struck me again in my postgraduate teaching that this again was an area that was not very well covered. So I started exploring it, and my interest grew more and more, started reading about it. And I passed my MRCOG. There was maybe a question or two, if that, in the whole exam. We didn't have the part 3 then. And subsequently, I had a chance to do research in this area. So I studied the effects of hysterectomy on pelvic floor dysfunction, and that is incontinence, prolapse, and sexual dysfunction as well. And also subsequently did quite a lot of work on childbirth trauma and pelvic floor dysfunction. And since then, I have been absolutely passionate about it. And I did my subspec training as well in this area. And you know, I think there's a lot of work that can be done. It's something I really love doing.
Perfect, great. And obviously you never look back.
No, never.
Okay, so Ranee, as you know, this podcast is aimed at educating patients. And as a result, we try to avoid medical terminology as far as possible so that it remains as accessible as possible to everyone.
Absolutely.
So let's start with the very basics. What exactly is vaginal prolapse? Is there a definition? Are there grades or stages?
I'll try and simplify this. So, the pelvic organ prolapse is essentially when one or more of the organs slips from its normal position. So, organs such as bladder, bowel, the uterus, and they subsequently form a bulge in the vagina. So, that's the sort of basic definition. And there are different grades, there are different ways of classifying them. But putting it simply, grade 0 is no prolapse, and grade 4 is a big prolapse or a big bulge. And the symptoms of them vary depending upon who it's affecting, etc. So we like to focus on symptoms rather than examination findings.
Okay, very well put, thank you. And that brings me beautifully on to my next question. What are the symptoms? So, what might a woman be experiencing that may prompt her to say, oh, maybe I have a prolapse. I'm going to go check this out. What are the possible symptoms of prolapse that women might look out for?
So that's a really good question because I find in my practice that often women mistake incontinence and prolapse. So they may have incontinence and they'll come and say, I've got prolapse. So the
Right.
symptoms of prolapse, and very important to distinguish between the two because they can occur together. So you can have a feeling of heaviness in the vagina or in the pelvis. You can feel a lump coming out. You may feel a lump. Some women may say that they felt a lump when they're having a shower and they suddenly notice that. Some women may get a feeling of prolapse when they lifted something heavy. So
Hmm.
those are the symptoms of prolapse. But along with that, because of the prolapse, say for example, prolapse of the bladder, they may have difficulty passing urine. Sometimes prolapse of the back wall of the vagina may be associated with symptoms of the bowel, so incomplete emptying of the bowel. So women may say, I want to push in the area of in my vagina or in the area between the vagina and the back passage. So all these symptoms can occur, Gail, and it's really important to remember that these pelvic organs are very closely related. So often you may get symptoms of one organ. So you may get a symptom of prolapse and lump in the vagina, and you may have incontinence along with it. They may be associated or they may be separate symptoms because you can have incontinence without prolapse as well.
Prolapse. Yeah. Okay.
But
So
what's more
prolapse.
important to remember, and something I must say,
Yes.
sometimes women may go to have a smear, for example, and the nurse or the doctor may say, "Oh, you've got a bit of prolapse." Well, that doesn't need treatment, and women get very worried about that kind of thing. So it's very important what clinicians say to women when they're doing examinations, because
Yep.
I see at least two women a week who will say, I've got prolapse. And do you have problems from prolapse? And they say, no, I don't have problems from prolapse. Somebody told me that I have prolapse. That doesn't need treatment.
Okay. Perfect. So, I always ask in all my podcasts about risk factors for the condition about which we're speaking, because there are some risk factors, for example, that can be mitigated or avoided altogether, perhaps by lifestyle modification. But there are other risk factors that you can't really change. And an example is your genetic makeup. You can't really change that. So, are there any risk factors that women need to be aware of? And is there anything that women can do to reduce their risk of having a prolapse in the future or decrease their risk?
Yeah, so that's a really good question. So there are lots of modifiable risk factors for prolapse.
Okay.
Um, One of the risk factors is pregnancy and childbirth, which we don't want to modify. But the things that can be modified are constipation, chronic
Hmm.
cough, heavy lifting, anything that puts pressure on the pelvic floor is a risk factor for prolapse. Besides that, aging, menopause are risk factors. But again, you can't do a lot about it. So, what we need to focus on are the things that you can modify. So, reducing weight, avoiding constipation, treating chronic cough. So, for example, if I see a woman who comes to me and says, I want to have an operation for prolapse, and she's got chronic cough, I always say to her, let's treat your cough before we do anything because it's likely to fail. And that's really important. What can be done to avoid it? That was your second question. The simple
Yep.
thing that doesn't cost a lot of money is your lifestyle factors, avoiding constipation, avoiding cough, trying not to put on weight. Weight is another
Yep.
high risk factor for that, and that's something we can do about. So, healthy living, lifestyle modification, and pelvic floor muscle exercises. Starting early. If I could start them during school days for young
Wow.
girls, I would do that. Because I think it's really important. And I often tell my patients, I say, we teach girls to exercise during in school, or we
Yeah.
tell them to exercise, but we never actually ask them to exercise their pelvic floor. And so for years, your pelvic floor lies dormant. And
Yeah.
suddenly, when you're pregnant, they say, you must do your pelvic floor muscle exercises.
Right. Okay. Gosh, that's an interesting way of looking at it, I have to say. And what about things like, I don't know, yoga, Pilates? Do you have any comment about that? You may not be, you know.
So there is some evidence depending upon who you talk to, but they all improve your general well-being. So they can only
Yeah.
be good for you.
Yeah.
Pilates is quite good for the core, and if you speak to some Pilates teachers, they firmly believe that it helps to sort of improve the strength of your pelvic floor, because what you're doing when you're doing pelvic floor muscle exercises, you're increasing the tone of that pelvic floor, which is a muscle on which all your pelvic organs sit, and therefore your pelvic organs remain in place. So that's what you're trying to do. Again, with yoga, there are very specific exercises that you can do, or yoga movements that you can do, that actually focus on the pelvic floor.
Okay. And in saying to women, do pelvic floor exercises, is there any advice? How would you advise they go about doing the pelvic floor exercises? Is it something that requires specific training, or is there something that if it's described to you, then you can do it effectively? What would be your advice to women who are watching this who say, okay, I'm going to start and I'm going to start my daughter doing pelvic floor exercises? How would you recommend they go about that, getting that information of how to actually do them?
So the evidence is that if you do supervised pelvic floor muscle exercises, you get the best outcome.
Yeah,
But that's in the ideal world. We unfortunately do not have enough pelvic floor physiotherapists, specialist physiotherapists. They're absolutely wonderful to
yeah,
help you actually learn to do the exercises. Um, and the success really depends on your motivation,
hmm,
and what you can learn from the person who teaches you. But in the absence of being able to be referred to a physiotherapist, because as I said, there is a shortage of them, but if you can see a physiotherapist, that'd be absolutely wonderful. There are lots of different things that you can do. You can look up the internet. There are lots of different organizations that provide you information. For example, the International Urogyne Association, for which I was the president, we have some wonderful leaflets, and we've got videos on there that can be used. You also have the Squeezy app, which helps you monitor the pelvic floor muscle exercises that you do, and actually guides you, gives you biofeedback on how to do
right,
it. So that's a really good thing to invest in, and it's something you can do every day, because the rule of the thumb, I mean, it's not fixed, but we say do it at least 3 times a day.
right. Okay, okay, great. So I'll put links to those resources in with the podcast notes. Thank you very much for that. Okay, and the next question is, at what age does it usually start or become a problem?
So, pelvic organ prolapse, prolapse of the pelvic organs, can start at any age. It can happen to young women, but it's more likely to occur as women grow older.
Yeah,
And that's because the collagen tissue changes not only in quantity, but in quality as well. And that's the effect of menopause, age. And it's a question of the easiest way for me to describe it is that when somebody gives birth vaginally, the tissue stretches, but you've
yeah,
got really good tone when you're young, and so you don't experience the symptoms. But as you grow older, your collagen tissue changes, and then you start seeing the symptoms of prolapse or incontinence. And that's why it's so important to do those exercises and keep on top of them right from the beginning.
yes. So keep them as strong as possible for as long as possible, I guess.
Yeah, absolutely. Yeah.
Okay. And the next question is, how is it diagnosed? So if I felt I was in the shower, maybe as you were describing, and I felt a lump, or I felt a sensation of something coming down, we say, um, when and I thought, okay, this is making me uncomfortable, perhaps, or I just want to check it out, and I went to my doctor. What would I expect? What investigations are performed? How is the diagnosis made? What can I expect when I go to my doctor?
So the doctor should take a history of the symptoms that you're experiencing. And I would say if you have any symptom of any of the organs that I just described, your bladder, bowel, or womb coming down, you should ask the questions of the bladder dysfunction, bowel dysfunction, what exactly you're feeling. And the most important question is how much is it bothering you? Because
Yeah.
if you're not really bothered by it and it's just something that you feel, you really don't need to have surgery or anything. But Gail, sometimes when I see patients, they're terrified because I felt this lump and they think I've got cancer. So I
Yes.
think taking the history is very important and reassuring women that this is a benign condition and the choice of treatment is made by you. It's also very important to ask questions about sexual function
Hmm.
because very often women will avoid sexual activity because they're frightened of having a prolapse. It's
Right.
important to remember that prolapse doesn't cause pain, it's a lump, it's a discomfort. So that history is important. And then the other accompanying history is, do you smoke? Have you put on weight? Do you do a lot of heavy lifting? All the other risk factors that I told you about. You want to find out how many children she's had, what type of delivery she had. And then it's an examination. And I
Yeah.
always teach my medical students, you always must examine the abdomen first because you could have a lump in the abdomen which is pushing the womb down. So that's really
Yes.
important to do an examination. You could have ovarian cancer, which is causing a prolapse. So examination of the abdomen is important. It has to be a big lump in the abdomen to push something down. And then a vaginal examination. And the vaginal examination is to look for prolapse either of the vaginal walls or to see if the womb is coming down. And also, very important to judge the tone of the pelvic floor when you're doing an examination. So, all urogynecologists and anyone who does vaginal examination can just do a examination of the pelvic floor. Ask the woman to squeeze around your fingers and
Hmm.
judge how good the pelvic floor tone is.
Okay. 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 Um, And moving along, so been to the doctor, um, have had the examination, and yes, there is a prolapse, and yes, it is bothering me. And before I ask my next question, I just want to put in that women who have the symptoms of something coming down, etc., vaginal bleeding, particularly after the menopause, is not a symptom of a prolapse, and that should be investigated. So if you've got any bleeding, then regardless of anything, you need to go along
Absolutely.
for that. Don't think it's part and parcel of a prolapse. That
Yes.
just occurred to me as you were talking.
Yeah, no, that's
Um,
important, but also bear in mind that if you have a big prolapse, it can sometimes come outside the vagina and rub
yes,
against your clothes.
absolutely,
So
yes,
there is a slight danger of being over investigated, but any
yes,
postmenopausal woman who has got any bleeding needs to be investigated.
yeah, yeah, okay. Okay, so yeah, so the prolapse has been diagnosed, if you like, and it's symptomatic. The next question is, what are the treatment options? What treatments would you expect a woman to be offered, or would you expect discussed with patients?
So first and foremost, there are some basic questions that I would ask. Has she
Hmm.
completed her family? Because that really makes a difference to how you plan the treatment. And then my second most important thing is how does it affect your life? And
Yeah.
then my third important question is what do you want? Because we are treating the patient. or the woman sitting in front of you. So my treatment is based around what she actually wants. And
Hmm.
what's really important to remember about pelvic organ prolapse is it is a condition that causes discomfort. Yes, it may not cause discomfort, but it's not like cancer. So I
Yeah.
often will tell my patients, if you had cancer, I'd be saying, in the next 2 weeks, I want to do this investigation. This is about your quality of life, and you can dictate what treatment you want. The important thing to remember is that one of the options is no treatment.
Yeah.
The second option would be doing pelvic floor muscle exercises, especially if it's an early prolapse, because then it's really useful. But if it's an big prolapse that is coming out of the vagina, bigger than stage 2 is what we would call that when we do an
Hmm.
examination, then pelvic floor muscle exercises may not be that useful. But it's still worth trying because it helps to tone up the pelvic floor. And if you do end up having surgery, then it's still good for you. So it's not going to
Yeah.
cause any harm.
Yeah.
So you can do pelvic floor muscle exercises. And then the next thing is, depending upon whether you want to have surgery or not, one of the options could be to try pessaries. So pessaries are essentially devices that you can put in the vagina that hold the prolapse up. And in my practice, I tend to use a lot of them. They come in different sizes, shapes. It depends on whether a woman is sexually active or not. It depends on whether she wants to change it herself or not. Now, we do know that lots of women are self managing pessaries as well. So they don't need to come back to the hospital. There is a trial known as the Topsy trial that has recently been published
Yeah.
that has shown no difference between self management and coming to the hospital. But in fact, self management was associated with fewer complications. So that's really good, isn't it? You don't need to come and wait in the waiting room, wait to see
Yeah.
the
Yeah.
doctor. You can change it yourself. Um, Usually, we say change it every 6 months or so. And that's not based on science. It's just sort of one way of managing it. Some people may change the pessaries every 3 months, some every year. But generally tend to say 6 months because, as you quite rightly said, she may have postmenopausal bleeding. It's a good way to investigate if you're doing that.
Yeah.
So the next option would be a pessary, self-management or herself, depending. I always start off with what we call a ring pessary. So it's a little ring that you put in the vagina, and it's amazing how well it works. And then there are more complicated ones, which called the Gail pessary or the donut pessary, etc., which I think need to be changed by a healthcare professional. Though I do have
Okay.
patients who change them. And the other thing which I must mention is that there is a pessary known as the cube pessary. So it's literally shaped like a cube, which can be inserted in the vagina when you want to do exercise or run. So if you have a problem, especially when you're doing some activity such as that, you can use the cube pessary, which sits in the vagina, and it can be taken out every day. So again, I have lots of women who use a cube pessary, and I'm very happy with it. Now, when that fails, or if you don't want to try a pessary, it's not for everyone, then you
Mm.
can have surgery. And surgery depends upon what prolapse you have. Is it prolapse of the bladder? Is it prolapse of the back wall? Is the womb coming down? And also to remember, if you've had a hysterectomy, you can still get prolapse of the vaginal walls. So that's
Yeah.
really important to remember because I sometimes have patients who say, I can't have prolapse because I had a hysterectomy, but it's the walls of the vagina that can come down.
Yeah.
So my surgical management will then depend upon what type of prolapse it is and what will give her the best outcome.
Okay. And some women as well assume that a surgery for prolapse will necessarily involve a hysterectomy. Can you talk a little bit about that, about what the actual surgical options are? In
So
brief.
the actual surgical option. So if you have prolapse of the front wall of the vagina, what used to
Yeah.
be known as a cystocele, we don't call it a cystocele anymore, we call it prolapse of the anterior vaginal wall, then you just need to have a repair of that front wall. If you have a prolapse of the back wall of the vagina, then you have a repair of the back wall. Now, sometimes you might find that the womb is coming down as well, in which case you may wish to do a hysterectomy. But there's also interesting options where a woman might, for example, want to keep her womb,
Yeah.
in which case we can fix the womb to tissue inside the vagina, ligaments inside the vagina, or there's another option where we may be able to keep the womb and attach a piece of mesh to the back of the uterus, and then that's attached to the spine. So that's one of the options. So I would counsel women on also based on whether they want to have a hysterectomy or not, if the womb is coming down.
Okay, so there's several options, and it just depends on the individual case, what the
Hmm.
prolapse is, and
Yeah,
most importantly, what patients want, patients'
yeah,
personal
yeah.
decisions.
And
Okay.
the other thing that I must mention also depends, like I said earlier, you may have prolapse, but you might have incontinence, you may
Yeah.
have bowel symptoms. So, what else do you need to treat? Do you need to treat incontinence, for example? Again, we would try conservative management first, non-surgical, and if that doesn't work, then our options of surgery could change depending upon what else is happening.
Okay. Thank you. So the other question I always ask is, does earlier intervention affect outcomes? So if I had symptoms and I thought, well, actually, I enjoy running, for example, and yeah, maybe I'm aware of a bit of a bulge, maybe when I run or whatever at the end of the day, it's not really bothering me that much. Um, would you say that um, no, it's fine. You can just monitor it, do your pelvic floor exercises, and see if things get worse? Or would you say, well, no, go along as soon as possible, because that will make your outcomes better?
Yeah,
Which would
so
you
so
recommend?
Yeah, so what I would recommend, start off with conservative management first. So
Yeah,
if, for example, you had symptoms only when you're running, I would say use something like a pessary to help you during the symptoms, not to rush to have surgery.
yeah,
Do those pelvic floor muscle exercises. If that doesn't work, then you can have surgery. And of course, you want to avoid surgery for as long as you possibly can, because if you have surgery earlier on, it is possible that as you grow older, you might need surgery again. And that's another thing I always tell my patients: your first surgery is your best chance. So give it the best chance you possibly can. The other important thing to bear in mind is that if you haven't given birth or you're planning to have more children, then it's better to leave it till you've completed your family, because pregnancy itself can put pressure on the pelvic floor.
yeah, yeah, yeah.
And
Okay.
the other thing to remember is if you do have surgery for prolapse and you fall pregnant, which can happen, I have patients who have that, then we would say that you need to have a cesarean section, because you do not want to give birth vaginally, because it might disrupt the repair that you've already done and lead to a higher chance of failure.
Okay. And what are the risks of treatment? So all those treatments, I guess, physiotherapy, there aren't any risks, I would imagine, particularly. Are there any risks that women need to be aware of that may influence what decision they make? Pessaries versus surgery, and can you talk us through, and of course there will be various risks, but can you talk us through the risks of surgery that you think are significant enough to warrant mention today?
Yeah, so that's a really good question. So, as you quite rightly said, pelvic floor muscle exercises, it is not without risk. Is without risk. Sorry, there are no major risks that one would worry about, but it's important to do it correctly.
Yeah,
That's perhaps the biggest risk is not doing it properly. With pessaries, the problem that can occur is you can get vaginal discharge, which some women don't like. It can be smelly. You can get bleeding, and that's the reason why we advocate changing it every 6 months or so, because it can erode the vaginal walls and cause bleeding.
Yeah.
But generally speaking, women who get on with it do extremely well. And a bit of research that we did in our unit, we found that if complications are going to occur or if failure occurs, it occurs within the first 4 to 6 months. And
Okay.
after that, women do extremely well with pessaries. Surgery is slightly more complicated, and it depends upon how big the prolapse is in the first place.
Yeah.
Um, Risks that can occur are bleeding, infection. This can happen with any operation, as you know.
Yeah.
There can be damage to the underlying organs. As I said earlier, all these organs are very closely related. So that damage can occur. It's rare, but it can occur. Some women may develop incontinence of urine. So if you replace the prolapse back, suddenly you might develop incontinence. It's rare, but it can occur. Some women may have difficulty passing urine afterwards. So those are the kind of complications that can occur with prolapse surgery. Um, the other thing to bear in mind is there are the anesthetic risks and also risks of clots in the leg and lungs, which we call DVT or pulmonary embolism.
Yeah.
And to prevent that, we would always give blood thinners after.
Okay. And can you give us an idea of how successful treatment is for women
Mhm.
with prolapse? So you've been quite clear that pessaries work really well for some women, and if you get on with it, it works
Mhm.
really well. Can you tell us about success rates of surgery? Because clearly that will influence women's decisions.
Absolutely. So I usually quote about 85 to 90% success rate for surgery. Obviously, with time, success goes down, but there are
Yeah,
lots of other factors that influence it as well. For example, if you have got really poor collagen tissue, then it's more likely to fail. And sometimes it's really quite frustrating because we don't get success. It's in that 15%. um, and then we need to look at what else can we do to ensure that prolapse doesn't recur. And it
hmm,
comes back to that reducing your weight,
great.
making sure you're not constipated, that you don't have chronic cough, all those things that can make you more likely to fail. All of those things that are risk factors for prolapse itself.
Okay. And an idea of, so if you have prolapse surgery, it is successful,
Hmm.
which you're delighted about.
Hmm.
What are the risks that maybe a few years down the line that it may recur? Do you have an idea, a ballpark figure about that?
Yeah, that's a good question. About 1 in 10 women with pelvic floor dysfunction will require surgical management, and that's kind of a rough figure. Um, the recurrence rate, it depends on which study you look at,
Yeah,
and it can vary from between 5% to about 15%. Older studies, one that is often quoted, quotes 20%, but we know from newer studies that it's perhaps not as high as
not as high
20%.
as
So
that.
I would say it varies, but again, it's about where the operation was done, who did the operation, the underlying factors, the woman's collagen tissue, and all the other
Yeah,
things that I spoke about.
yeah, yeah, yeah. Very multifactorial.
Hmm.
Okay. And then the last question for me is, can you tell us a little bit about the use of mesh in prolapse surgery? Women, well, many women will be aware that this has been an issue. Can you tell us a little bit about when mesh is used, perhaps? Is mesh still used? Can you just speak a little bit around that? Because I'm sure a lot of women will tune into this podcast to learn more about that.
Yeah, I think that's a fair question. We currently have a period of high vigilance restriction in place in England. which means that a mesh can be inserted only in exceptional circumstances. So I would say, in my practice, or looking around in England, mesh is not inserted in anyone. I cannot see there being a good enough cause to insert vaginal mesh, and it's really important to distinguish between mesh that is inserted through the vagina, and then mesh that is inserted for prolapse, and mesh that's inserted for incontinence.
Yeah.
The mesh that is currently used in England is the mesh that is placed abdominally, and that is for sacrocolpopexy, sacrohysteropexy, and these operations work really well, and there's no restriction on that mesh. It's mainly the mesh that's inserted through the vagina.
Okay. Okay. And just to clarify, the mesh, a sacrocolpopexy or sacrohysteropexy is where a little bridge of mesh is stitched onto the either vagina if a woman has had a hysterectomy or the
Yeah.
uterus if she hasn't, and which elevates it by, like you said before, attaching it to the bones of the bottom of the spine. Whereas the other mesh is
Mm.
mesh that are used under the pipe, the
Yeah.
urethra that
Yeah.
leads from the bladder, and used more for incontinence. Is that just to
Yeah.
clarify in women's minds because it can be
Yes.
quite confusing?
That's very, very good question. So the sacrohysteropexy is where, remember I told you, if somebody wants to keep their womb, one of the
Yeah.
ways could be fixing it through the vagina, but the
Mhm.
other way of doing it would be to attach a mesh to the back of the uterus or the cervix, and then attach the other end to the anterior longitudinal ligament. So it's a ligament on the spine. So it doesn't go into
Yeah.
the bone, it goes into that ligament.
Yeah.
A sacrocolpopexy is when a woman has had a hysterectomy and the top of the vagina starts coming down. And
Yeah.
then what we do is you can attach a mesh to the back of that vagina, and then that's attached to the anterior longitudinal ligament. The mesh that you talked about for that is inserted through the vagina, one can be for prolapse, which is not available, almost not available, not made by any company. And the other one is the TOT or transobturator tape, again, not available. Most companies have stopped making it. But tension free vaginal tape or TVT was the one that was used for urinary incontinence, which
Yeah.
was the most popular one. But in the UK, we are not using any except abdominal mesh.
Okay. And there's no restriction on that.
There's no restriction on that. Yeah.
Perfect, great. So thank you for those clear and detailed answers to my questions. As you know, before every podcast, I invite patients, the public, to submit questions, which I ask the expert on their behalf. Are you
Hmm.
happy for me to ask you some questions that have been submitted by my listeners?
Yes, absolutely.
Okay. So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care should be sought from one's own doctor. Okay, so our first question is, why is prolapse not discussed in prenatal care? Why is it a taboo subject for young women?
So that's such a good question, and it shouldn't be so, isn't it? So the RCOG did a huge survey, and we found that a large number of women do not actually complain about their pelvic floor dysfunction symptoms. So just the data is that over 60% of UK women have at least one symptom of poor pelvic floor health, and that is quite shocking.
Yeah.
And majority, 69%, have not spoken to anyone in the NHS about their symptoms. Um, when women were asked why they didn't talk about their symptoms, the answers were simple. something we have known for a long time. Many women thought it was normal, it was part of childbirth, it was part of
Right.
growing old, and some are too embarrassed to ask about it. It's still a taboo subject. And that's why we need to increase awareness, we need to increase education, and we need to remove the stigma so that women feel that they can ask. I think we are getting there somehow. So things are very different from when I started my career in this area of urogynecology.
Good.
Almost never anybody never spoke about this subject. Um, I can remember in my mother, if I spoke to my mother, you would never ever get her to talk about this subject, even after I became a urogynecologist.
Right.
Whereas
Okay.
now, but now you see lots of people. My niece talks to me about it, and so I
Good.
think things are changing, and I think that's really good news. The other really fantastic news, I think, in England is the perinatal pelvic health scheme that has come up. It's a NHS England project, which has provided funding to what we call early implementers and fast followers. So they're units throughout the UK, to improve pelvic floor health in pregnancy and after childbirth. And I think this is going to be really fantastic, because the NHS long term plan is that by 2024, every woman will be able to receive advice about pelvic floor muscle exercises and increasing awareness antenatally and postnatally. And
Fantastic.
I think that's really fantastic news.
Okay.
This has been happening in France for years. It's something we never had.
Great. So hopefully things will change. But the take home message is if you're concerned, if you're worried, don't be embarrassed. Don't suffer in silence. Come, that's why we're here. That's
Yeah.
why we're here. Come forth, ask a question, whatever. And that's the genesis of why I do this podcast. To,
Yes.
to just to be able to reach out to people and say, loads of women have similar problems, for example, come
Yeah.
forward, so that you can be helped.
Yeah.
Okay, the second question is I would really like to know if anything can be done for pelvic prolapse and stress incontinence when the bladder is slow. I've been told there's nothing at all, not even physiotherapy, when slow bladder is involved.
So I would like to obviously ask a few more questions over here,
Yeah,
because this comes back to what I said earlier. You can get prolapse, but then you can have other symptoms as well. So
yeah.
if you have a prolapse of the bladder coming into the vagina, what we call anterior vaginal wall prolapse, you can
Hmm.
have a slow flow, and that is because the urethra, or the tube from where you pass urine, can get kinked by the prolapse, and that can cause a slow flow. So I'd be interested to know if whether the slow flow is because of poor function, so your bladder is not able to squeeze urine out very well, and that can cause a slow flow, or is it because the prolapse is obstructing it or kinking the urethra, and therefore you're not able to. Because if it is because of the prolapse, then fixing the prolapse will improve that.
Yeah.
Whereas if it is a slow flow and your bladder is just not functioning that well, then it's a little bit more um, difficult. But my question to the to your patient, or our patient,
Hmm.
would be what bothers her more? Is it the difficulty passing urine, or is it the lump in the vagina that bothers her more? And how much does it bother her?
Okay. And is there any way to tell which it is? Would it require further investigations to determine if it's the prolapse or if it's the bladder that's
Yeah. So
the main
so
issue?
Yeah, absolutely. So you'll need an examination to find out
Yeah.
what kind of prolapse you have,
Yeah.
and we might have to do some further studies known as urodynamic studies. And urodynamic studies essentially tell us how your bladder is functioning.
Yeah. Yeah.
And also maybe a cystoscopy, where we pass a little telescope through the tube where you pass urine from, and have a look to see whether there's anything obstructing over there. So that can
Okay.
happen as well.
Yeah. Okay. So basically, the advice is with similar situations, maybe go back and see if they haven't had these investigations. Maybe that's another the first kind of next port of call.
Mm-hmm. Mm-hmm.
Okay. So next question. I've always enjoyed running, but I'm concerned that it may make my pelvic floor worse since I've had children in quick succession. Should I stop or reduce my running to protect my pelvic floor?
We don't want anybody to stop doing what they enjoy doing,
Enjoy.
isn't it? So you have
Yeah.
to find ways. One is to, by all means, please go and see your doctor, go and see your physiotherapist. You could use the pessaries that I spoke about earlier and
Yeah.
continue doing those pelvic floor muscle exercises. So there are things that can be done, especially if it occurs at that particular moment, for example. But don't stop running, because that's going to be good for your well-being. You're not going to put on weight, all of which are risk factors for prolapse.
Perfect. Okay, the next question is I have been diagnosed with a cystocele and rectocele and awaiting a hospital appointment. I don't have any leakage, but I do suffer from back pain. Can this be caused by the prolapse?
Yeah, so sometimes women who have prolapse may complain of lower back pain, but it's only very big prolapses that can cause back pain. If you have slight prolapse, it really shouldn't cause back pain because not pulling on anything as such. But big prolapses can sometimes cause lower backache. It's also important to remember that you can have backache without a prolapse.
Yeah.
And so it's important to get investigated for back pain and maybe get referred to a physiotherapist to look at your back or to do some exercises. So remember that prolapse doesn't always cause backache unless it's a big prolapse.
Thank you very much. Great. Okay, so the next question is I had big babies and a prolapse repair 7 years ago. The prolapse has come back, and I was told that I should avoid further surgery due to scarring and other risks. I need to push the prolapse back to empty my bowels. Is there anything further that can be done?
Yeah, that's a good question. So this lady has had a prolapse surgery in the past, and that
Yeah,
has come back. And you're
yeah,
absolutely right. The more surgery you have, the more scar tissue you have. And what one wants to avoid is shortening of the vagina that can occur with recurrent prolapse surgery, and which can cause pain during sexual intercourse later on in life. So you want to avoid surgery as much as possible. It's not a no surgery. It's avoid surgery. That's important. But the other important thing that you just mentioned was that they were having to push back the prolapse to empty their bowels. So my question again would be, which one bothers you more?
yeah.
Is it the fact that you are having to help yourself to empty your bowels, and this is not uncommon. It's nothing to be ashamed of. It's a question I ask everyone when they come to me with prolapse, and it's more common than you actually think. Um, and if it's the bowel symptoms that is more bothersome, it's unlikely to be helped by repair of the prolapse, because what you need dealing with is what we call obstructed defecation, which is rather mouthful, but what you describe, having to actually help yourself to go, is called obstructed defecation. And a visit to a colorectal nurse or the physiotherapist who could go through bowel dynamics with you, teach you a few things, could be very, very useful, and you may actually avoid surgery for that. Again, it comes back to what bothers you more. Is it the prolapse or is it the bowel function? And that's how I decide on what I'm going to treat first.
Wow, that's really, really useful information. And just thinking slightly out of the box a little bit to think actually, yes, you have a prolapse, but there may be a primary bowel problem that needs
Mm.
investigation, assessment,
Mhm.
rather than more surgery. So just kind of take a holistic approach and look at all the organs, because as you say, everything is right next door to the other. They're so
Mhm.
closely packed into the pelvis that one
Yes,
thing affects the other.
absolutely.
Okay, so the next question is, can vaginal prolapse be reversed? My mum had a hysterectomy many years ago and it left her with this condition.
Yeah. So, as I said earlier, sometimes you can have a hysterectomy and the vaginal walls can come down. Can that be reversed? If it's early prolapse, up to stage 2, it can be helped by doing pelvic floor muscle exercises on a regular basis. It might reduce slightly, it might remain static, which may be acceptable.
Hmm.
Um, and then again, the lifestyle modifications, now putting on
Yeah,
weight, avoiding constipation, avoiding lifting, and all of that can actually help it from getting worse. So it depends on how acceptable it is. It depends on how much it is affecting quality of life. Comes back to the same question. Somebody's prolapse may affect her quality of life much more than another woman's prolapse. Every woman is different.
yeah, absolutely, absolutely. Okay, so the next question is, the psychological impact of prolapse is often not recognized. Why is this the case? As having a significant postpartum, so that means after delivery, prolapse, why is this not as recognized and managed as physical symptoms? So the question is, so this listener's had a prolapse after she's had a
Mm.
baby, and I guess she feels that the physical symptoms have been addressed,
Mm.
but the psychological impact of prolapse, I guess she feels, hasn't really been addressed. Any thoughts about that?
Yeah, so that's a really good question because we do have evidence that uh, that prolapse symptoms can actually cause dysfunction in body image as well, and there is scientific evidence, and it's something that we don't deal with quite so well, or we don't even ask as clinicians. So I think when we are dealing with anyone who has pelvic floor dysfunction, it's really important that you take into consideration how much is the physical aspect, how much is the psychological aspect, and if it's affecting somebody's mental health so much, they should get referred accordingly. We tend to refer patients to talking therapies if we think they need help, and we work very, very closely with them. In fact, they come to our clinic every 2 weeks or so. And if we find somebody who we have managed to help, but she's still not happy because of the symptoms of prolapse, or or she's so psychologically traumatized by the whole thing,
Hmm.
it's worth going and talking to somebody who is an expert in that area.
Absolutely. The next question, well, I think you've answered this already, but I'll ask it because sometimes you might feel you have something to add further. What preventative management can be done to prevent a prolapse? And, maybe we've covered that. Is there anything you'd like to add or?
Yeah, so I think the important thing is to do your pelvic floor muscle exercises regularly, avoid putting on weight, avoiding constipation, avoiding heavy lifting. These would be the main things that you can do. We can't prevent aging, and we can't prevent menopause. I wish
Yeah,
we could, but we can't. But
not yet. Yeah,
so we need to focus on the things that we can reverse to help us. And these things do. There is scientific evidence as well around it.
definitely. Oh, great. Okay, good. What is in place for the mesh patients following the mesh surgery that is not now best practice?
Yeah, so there are the specialized mesh services that have been commissioned. There are in England. They are also available in. There's one in Scotland as well, Northern Ireland and Republic of Ireland. Mesh centers have been set up. In England, obviously, it's NHS England that have funded these, and they provide a whole scale of holistic care, right from pain management to operation to conservative management, and also help with mental health, and the whole thing
Yeah.
has been extremely well funded to support women who have mesh complications.
Good. That's very reassuring. Okay, the next question is why are there such delays in service provision?
Very good question. The reason is the, well, I hate to say this, but pelvic floor dysfunction is one area that has been woefully neglected. Women's health is neglected, generally speaking, and it's something that as
Yeah,
college we advocate for, as you well know, Gail. But
absolutely.
within that, the field of urogynecology or incontinence of prolapse is again a hugely neglected area, and it's neglected, I would say, for various reasons. Women don't complain about it, as we discussed. Women are embarrassed, they feel that it's part of normal living, or they feel help is not available. And as healthcare professionals who look after these women, we need to be advocates. So there's a huge need for increased awareness, education, and providing education in the form that is palatable to women. So the way my mother's generation would receive treatment is very different from the way my niece receives would receive treatment. So my niece spends her whole time on her iPhone. I'm talking about her. She's sitting out there. She could be cross. Is they look at TikTok, they look at Instagram,
Yeah,
and all of that. And why don't we use those ways of providing education to
yeah,
women in a way that is acceptable to them? So we've got to start thinking outside the box. The other problem is resources. They just aren't the resources, and even if there are resources, we do not have enough physiotherapists trained to actually teach to do pelvic floor muscle exercises, etc. So while patients are waiting to get appointments, what they can do is try and empower themselves with information and look at ways of actually starting to help ourselves, improving our quality of life and lifestyle interventions, all of which we can all do.
yeah. That's a great answer. Thank you. And the last question from our listeners, why is surgery not the first line management for younger patients, for example, in their 30s?
Yeah, so I'm not saying that it is not an option. It could be an option, but I think, as we discussed earlier, Gail, it's important to do the first surgery is the most optimal surgery. So you do
Yeah,
not want to do it too early on in life, because, as we've discussed, the risk factor is age,
yeah,
menopause as you grow older, and so you want to give the best chance. Also, if, as we mentioned earlier, if you haven't completed your family, then it's better to do everything else that can be done and then go for surgery later on if there is no other option, because surgery is not without complications.
no, absolutely. Okay, so I have one final question, and that's from myself.
Mm-hmm,
Rani, you have managed many, many women with vaginal prolapse in your career thus far.
mm-hmm.
Given the opportunity, is there anything you'd like to say to women who either think they might have a prolapse or have been diagnosed with a vaginal prolapse?
So, what I would say to anyone who thinks they have prolapse or possibly are suffering from prolapse is, do not suffer in silence. Go to your doctor, try and read, see what's around, empower yourself with that knowledge, and do not be afraid to ask. And from a clinician's point of view, we need to improve our understanding of this area. I think it should be included in all curriculum, and it's something that we are working on the RCOG, including it in core curriculum. Just simple, basic questions. It needs to be part of education for GPs, nurses. I think during the life course of a woman, She can get pelvic floor dysfunction starting right from puberty, when she's pregnant, when she gives birth, and in the menopause. So there are so many touch points
Yeah.
that one can actually use, because all of these are touch points where a woman might go to a doctor or a healthcare professional. And therefore, my dream would be every healthcare professional even ask just one question: do you have incontinence? Do you have prolapse? Do you want help? And if we get everybody to do that, there will be increased awareness. We'll know where to direct patients, and we'll be doing the right thing for the women we look after.
Brilliant. In closing, Ranee, it just remains for me to say thank you. Thank you so much for sharing the wealth of your knowledge about prolapse with us today. Thank you for supporting my efforts in educating patients. And thank you for your tireless work in helping women with vaginal prolapse. Also, thank you for your sterling work with the Royal College of Obstetricians and Gynaecologists and helping countless women across the globe with women's health. Thank you so much.
And thank you, Gail, for having me. I enjoyed this. I never tire talking about this subject.
Your passion is very, very clear. Thank you so much, Ranee.
Thank you.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.